Hey guys, my name is Caitlin Elms, and I am gonna discuss fetal non-stress testing with everybody today. So what is a non-stress test? An non-stress test is an NST, that's the abbreviation. It's used to measure fetal heart rate in response to fetal movement. During a non-stress test, the term stress means no external factors are placed on the fetus. So there's no medication being given to the fetus to change the heart rate or change the uterine contractility. Mom isn't having anything done to her. She's just sitting at rest. This is just a baseline of fetal heart rate. The non-stress test is performed for 20 minutes initially. And if the fetus is reactive, which we'll get into later, the test is complete. If it's not reactive, then the test could be extended for up to 40 minutes. So if you see here at the screen, the top chart is the fetal heart rate, which we like to see between 110 and 160. And these mountains are accelerations, which there's different levels of accelerations that fetuses need to have based on gestational age. We also want to see variability, which is beat to beat heart rate changes. And then the bottom line is uterine tone, which could indicate contractions, or this one says fetal movement. There's no way to really prove that that's fetal movement on the TOCO or the contraction monitor. It just could be like some irritability or just a movement, or if the mom pressed the button on the contraction monitor. The history of the non-stress test. So the first fetal audible heart tones were noted in the 17th century. So this is when they first realized that in utero, the heart rate of the fetus could be noted. The first non-stress test was introduced in 1975 by Freeman and his colleagues, and this has kind of been the gold standard of overall fetal health. Is like the first line testing. It's currently what's used by the American College of Obstetrics and Gynecology, or ACOG, and then AWON, which is the Association of Women's Health Obstetrics and Neonatal Nurses. The procedure for performing an NST. First, you want to have a patient empty her bladder, because if the bladder isn't empty, then there could be uterine contractions that are occurring just from the pressure from the bladder exerted on the uterus. Next, you want to perform Leopold's maneuver, which is when you use your hands to feel from the top of the uterus to the bottom to kind of assess the baby's position or lie. This is going to help you with placing the external ultrasound piece to determine the best place to hear the fetus's heart rate. The best position to hear from them is through their back. So if they're turned facing you, sometimes this can indicate that it might be softer if the baby's spine is lined up with mom. Another obstacle here is if the patient has an anterior placenta, that means it's on the front wall of the uterus, so will kind of cause muffled heart sounds of the baby. So next, once you determine the fetal lie, you're going to place the external ultrasound piece on the mom's abdomen, and you'll secure her with straps to keep it in place. And you'll also use gel so it can be heard. Then you will feel the abdomen, feel for the top of the uterus, which will be determined based on how far along the woman is. If she's earlier, it's going to be closer to the belly button. And if she is further along, like 35 weeks, 40 weeks even, it'll be further up. It does get easier to feel the further along they are. Also, if the patient is contracting, it is very easy to find the top of the uterus. Some indications and contraindications for NST. So I worked in high risk for 4 years, high risk antepartum, and then I work in labor and delivery currently. So NSTs are performed a lot of times after 28 weeks gestation. If we perform these sooner than this, it's not really going to give us indicative results that are representative of the fetal health. Babies shouldn't have accelerations until they're 28 weeks. Before that, you can have a lot of changes in the heart rhythm that are normally expected. So it wouldn't be a good representation of fetal health. If you're a high-risk pregnancy, like you have premature rupture of membranes, preeclampsia, if you're expecting multiples, if you're over 40 weeks, if you're Rh negative, or if the baby has a known anomaly like IUGR, these would all be indications to do an NST. Contraindications, like I said, earlier than 28 weeks. So between 24 weeks and 28 weeks, we can do an NST. And whenever I worked on high risk, we would do them. But a lot of the times it's almost like you're looking for a problem. And if you look long enough, you will find something, especially on the high risk unit. These women are admitted for a reason for inpatient monitoring for the duration of their pregnancy. So you're going to expect more variables. The fetus is going to be smaller during this time, and you might not have those accelerations as you would expect. So it could have a non-reassuring NST, which could cause anxiety in the mother. If the baby is healthy and there's no indication from the provider to do an NST, then that would be another reason for us not to look further. So interpreting an NST, so there's lots of classes you can take to learn about this. So currently I'm through advanced fetal monitoring, and I'm about to take my certified fetal monitoring course next week, actually. Normally on an NST, from 23 weeks, it's kind of the beginning of where you could actually do one. You shouldn't, but you could, to 27.6 weeks, and you're going to see variability. So variability is the beat to beat changes. So it kind of makes it look like jaggedy in the heart rate. And that just means the placenta is perfusing the fetus adequately. From 28 weeks to 31 and 6 weeks, this is kind of when we should be doing them, and there's a benchmark. This is what we need. If you're not getting this, we need to figure out why. So the benchmark is 2 accelerations in a 20-minute period. So earlier when I showed a fetal strip, you want to see the heart rate go up from the baseline, which you need 10 minutes to establish a baseline. You want to see it go up by 10 beats for 10 seconds twice in a 20-minute period. These are called accelerations. And if the baby does this twice, then they would have a reassuring NST. So there's no cause for concern that the baby is acidotic at this moment. The problem is this stuff can change rapidly, and this is just a snapshot. At 32 weeks, there's kind of a higher grading scale. You have to have 2 15 by 15 accelerations in a 20-minute period. So this means that the heart rate has to go up from the baseline by 15 for 15 seconds twice. So let's say the baseline for the baby, you put the mom on the heart rate monitor, and the baseline is 120. So that means most of the time in the 10-minute period, it's at 120. So in order for a 32-week fetus to have a reassuring NST, the heart rate would need to go up to 135 twice for 15 seconds in that 20-minute period. If the baby was able to do that, then we would say it's reassuring and we wouldn't have to continue with another NST. As you progress onward, the threshold for what you tolerate in an NST lessens. So earlier when I said you can have decelerations, some abnormal findings in an NST would be if you aren't getting that variability, if the heart rate isn't really changing at all, and it kind of looks flat. Another thing is absent acceleration. So you could have the heart rate changes, but not the accelerations that would indicate a reassuring NST. Another thing that can happen is variables. So variables is when the heart rate suddenly drops down, and they usually look like a V or a U, and it could mean that the baby rolled on the cord, there's cord compression. So we kind of want to positionally change mom to help the heart rate come back up and make sure this isn't a recurring issue and it just was a random occurrence. When the babies are earlier, will tolerate more variables. They're normal. Their fetuses is smaller. They can move around more. They have more space in the uterus. But as we progress in gestation, we don't really want to see variables, especially recurrent variables, because it has to make us think, is something else going on here? Why is this happening? More concerning than variables are prolonged decelerations. So in order for it to be a prolonged deceleration, it has to occur over 2 minutes. So if the heart rate was 150, it would slowly need to go down to 15 beats below and then slowly come back up. And those kind of look like wide U's or a parabola. Very concerning, especially if a baby is further on. If you're in labor, a prolonged decel could be indicative of fetal descent progression. So if a mom is like advanced dilation, like 9-10 centimeters, we're going to tolerate it longer because she's almost going to have the baby. But if she's not, that would be a reason to get a C-section. And then the most concerning is a non-reactive. That kind of goes hand in hand with the minimal variability and absent acceleration. So just a flat strip. It could mean that the fetus is having a normal sleep pattern. Babies usually sleep in the womb as well for up to 25 minutes. So that could mean we need to give mom juice or something cold or turn her or use vibroacoustic stimulation, which at all the hospitals I've worked at, I've never actually seen a true device for this. We usually use a razor, a vibrating razor we use to shave patients for C-sections, and we'll buzz the belly. Follow up. So it's going to depend on the gestation and the interventions we do, and then further assessment. So when I worked on her high risk, if I had a patient who had a non-reactive NST, I'm going to turn her. I'm going to give her a fluid bolus as long as she's not preeclamptic. I'll give her juice if I need to. I'm going to notify the provider. If I've watched 20 minutes and there's nothing going on, it looks really flat, and I've done those things, then we'll watch a little bit more, and then we'll ultimately call the provider and be like, hey, I think we need an ultrasound or a BPP. A BPP is more representative of what's going on because it's going to look at fetal movement. Is the fetus breathing? Is there adequate fluid? It's going to pay attention to all those different characteristics, and it'll be scored out of 8. So you get points for each one the baby does in the 30-minute period. They will give them the whole 30 minutes, but it should not take them that long to get all 8 of those if everything is okay. Advantages and disadvantages of NST. So advantage is it can offer reassuring fetal heart rate and pattern, and it can say like, hey, the placenta is doing a good job oxygenating the fetus. And we can look at a good heart rate rhythm and say, okay, there's normal acid-base balance. The disadvantages are it definitely causes a lot of anxiety in patients and moms because they're strapped to this monitor and a lot of them don't understand or haven't been taught how to interpret it correctly. If there is a deceleration that occurs, it could just be a normal, like benign finding of the baby squeezing the cord, but we're going to run in there and turn you quickly and definitely really stress them out. Also, the fetus just could be sleeping. It's not a good representation overall because it's not telling you the whole picture. It's a snapshot. The heart rate is going on 24 hours every day, all day in uterus. But we're looking at 20 minutes and trying to say, okay, everything looks good. Well, it may have looked good in this 20 minutes, but an hour later it might not. So things can change rapidly. Yeah. Almost sometimes I feel like we're looking for problems. Patient education. So if they're interested in learning, definitely educating them. Some people get very triggered by listening to the sound. So I always discuss with patients if they're anxious, if they want me to turn the sound off, and just kind of explain to them what I'm watching for, what I'm doing, and if something was wrong and I came in quickly and asked them to turn, like they need to move quickly. Some patients do get frustrated with this, especially when I worked on high risk, like with people whose water broke early with PPROM, they'd be there for a few months at a time. So they're getting these tests sometimes 2 and 3 times every day for months. Some of them get really interested in it, and I really enjoy teaching patients how to interpret it so they kind of know what's going on. People are a lot more amenable and agreeable if they understand the why we do what we do. One non-stress test has really little diagnostic value. We're going to need to collect more data. We can't just say from one test unless the baby has a prolonged or the heart rate drops super low and isn't coming back up. Like, we can't tell you definitively. We're going to need to gather more information. And like I said previously, a non-reactive stress test could mean a normal fetal sleep pattern. But this is why it's really important to discuss like fetal kick counts and movements, and for moms to pay attention at home when they're pregnant, the times of day that their baby usually does move or be more active. These are my references, and I'm sure as you all learned, NST is something I'm very passionate about. So if anyone wants to talk about it further, or has any questions, please feel free to let me know. Thanks, guys.